Hello everyone. Here's a talk that I presented for Lancashire Optometric Society in February 2020. It's a talk about the research that I've done and how it applies to optometric practice. There's many different definitions of dizziness, from a purely descriptive one, such as affected with a whirling or reeling sensation from the Collins English Dictionary, to Yardley's a non-specific symptom, which, in my opinion, isn't actually that useful. My favourite definition is an uncomfortable, disturbed state of spatial awareness, and this is Warner's definition, and in my opinion I think it's suitably vague because dizziness is often something that people regard as a pretty vague symptom. So how do we categorise dizziness? Well, Drachman and Hart in 1972 came up with this classification, which is commonly used in dizziness research. First of all, we have vertigo, and that happens when someone feels as if they're spinning or they feel as if their surroundings are spinning. There's disequilibrium, and that's the feeling that you can't keep your balance, so you might want to put your hand out and hold on to something even if you're standing still. Then we have presyncope, and that's the feeling of unsteadiness you get when you're about to faint. And the last one is lightheadedness. There's no clear explanation for this one, and it can be associated with the feeling they get when you stand up too quickly. It's also associated with stress or psychiatric problems. Been established that dizziness is in fact multifactorial, and it has been called a geriatric syndrome. Remember, a syndrome is a group of symptoms that often occur together. So if it's a geriatric syndrome, you might want to group together problems such as being unsteady on your feet, having weaker muscles, feeling dizzy in the head, or a general feeling of instability. Dizziness is also something that we feel may be underestimated in the population, mainly due to problems with patient recall, problems with different studies defining it differently, and of course the very people who may show more dizziness symptoms, and that's the frailer people in society, may be excluded due to memory problems, that kind of thing, so you might not actually get them included in the study that you're looking at. One thing that we do know is that the more risk factors you have, the more likely you are to have dizziness. So here are the main risk factors for dizziness, and you'll notice that we've got things like age, female gender. Obviously we can't do anything about that as optometrists. Polypharmacy, that's where you're taking many different medicines, and that inevitably means that you've probably got many problems health-wise. We've also got problems such as anxiety, motion sickness, but the one that we're really interested in as optometrists is visual impairment. So if an optometrist is going to be able to help someone who's dizzy, first of all, we have to know that they're dizzy. So how do we know when someone's dizzy? Well, the first thing is they'll generally tell you. Just be aware though that there's quite a lot of very vague symptoms that people use, and actually they're describing dizziness. It's also important to remember that it's a very subjective experience. So what might be completely unbearable to one person is actually just a mild discomfort to another. Here's quite a few of the descriptions that you get from people who are dizzy. So floating, swimming, faintness might not actually conjure up images of dizziness to you, but it's important to remember that these might be the words that are used by a patient who is describing dizziness. Also, you can watch your patient. If they hold on to things as they walk into the room, they may appear confused, they may even appear intoxicated. So of course it's best not to make judgments, but just consider that if someone is behaving like this, they might actually be suffering from dizziness. So if we're going to be interested in dizziness, first we need to understand about balance control. Balance is achieved when you have your visual, vestibular and proprioceptive systems working successfully together. And to produce postural stability, the majority of the time we're actually totally unaware of this process. The body needs to appreciate the spatial location, determine the speed and direction of movement, and at the same time make appropriate corrections to your posture just to stay stable. So the first thing that we need to stay stable is the visual system. And achieving postural stability uses central and peripheral optic flow, as well as retinal image and eye movements, to monitor the body's position and movement in space. Next, we have the vestibular system. Remember back to your anatomy lessons, and you remember that you get the 3 semicircular canals, which monitor head movements and acceleration. Hair cells bend when the endolymph moves, and sensors in the utricle give information about rate and direction of movement. And finally, we have the proprioceptive system, and this gives us an awareness of the position and movement of our bodies in space. Information from the 3 systems is integrated to transmit impulses to the motor system, and this gives us an awareness of where we are and how fast we're moving. And then these signals allow us to make tiny movements to retain our posture, to keep ourselves in the right position. And this system's constantly in use. As we breathe, we make tiny movements that then have to be compensated for to keep us balanced. If you want to try that out, all you have to do is stand on a cushion, and you'll find that you can feel in your feet the tiny little movements that are happening all the time, just to help you keep your posture. Here's a diagram that shows how motor and sensory systems that control balance are connected. So now we know the complexities of a working balance system. Let's have a little look at what happens when it fails. If the balance system fails, we fall over, and this comes at huge cost. In monetary terms, we're talking about £4.5 million per day, and this is made up of emergency care, secondary care, long-term care, medication, adaptations that need to be made, such as grab rails, etc. But also, it's not just the monetary cost, it's the emotional consequences, the pain that a patient has to go through, the fear of falling. They might become withdrawn, they might fear leaving their home, and as such they might restrict their activities. They might feel embarrassed because people think they're unsteady on their feet, maybe think they're intoxicated, and this can lead to loss of independence. When we compare falls and dizziness, we find that they're very closely linked. In fact, dizziness is the 3rd most likely cause for falls, and between 10 and 20% of falls, dizziness is a major risk factor for them. It also leads to much reduced quality of life. It's not all bad though, because dizziness might actually serve as an early warning system. It might tell people to hold on because they're about to fall over, so it does have its purposes. We know that visual impairment is a risk factor for dizziness and falls. And I've just explained how the visual, vestibular and somatosensory systems are integrated to control balance. The other reason why we think that visual impairment is a risk factor for dizziness and falls is because of the vestibulo-ocular reflex. Vestibulo-ocular reflex is the body's mechanism for keeping images stable on the retina whilst the head moves. When the head moves to one side, the eyes move in the opposite direction by exactly the same amount. In an uncorrected emmetrope, the ratio of head to eye movement is 1, and we say that the VOR gain is 1. Now this process is really rapid, there's only 3 neurons involved, but we know that the visual input is slow, so this particular reflex is driven by the vestibular system, and we know this because it still works even in the dark. So let's throw something else into the mix. What about if the spectacles are magnifying the image? Here's the big scary formula that we've all learnt before. And we all know that if we've got a substantial prescription, we also have a substantial change in the image size. As the image size changes, the VOR gain must change, and eye movements have to be recalibrated. So with a plus lens, we get a larger image, and with a minus lens, of course, we get a smaller image. So when a larger image moves, we've got a greater movement. So between the top and the bottom of the tree, we've got a much larger movement. And our eyes then have to be recalibrated. The other way round with a minus lens. So we've not only got a smaller image to contend with, but we've also got a direction change. So that's the VOR explained. So next we need to have a little look. What do we actually mean by visual impairment? Well, as optometrists, we're all pretty obsessed with how far someone can read down the letter chart, but that's not what visual impairment is in total. We also know really that it's actually happens because of distortion, and that could be spectacle lens or corneal. It could be because of double vision. It could be because of field loss or contrast sensitivity. So bear all these in mind when you're thinking about visual impairment. So first of all, we've got functional problems. So that's blurred vision. And we know about these. We know lots about this as optometrists. So we're looking at uncorrected refractive error. We like that one because we can normally fix it. We've got people with cataracts. They've got blurred vision. Dry eyes can also affect the ocular surface, and that makes your vision blurry, be it permanent or temporary. And then we've got the eye diseases that we know all sorts about, which is glaucoma, diabetic retinopathy. The list could go on for ages. And next we've got distorted vision, which could be due to macular degeneration. It could be due to a macular hole, keratoconus, like in the image on the top right hand side here. We also get sometimes migraine is referred to as a distortion. So I put this image on really to show you how disconcerting diplopia can be. And we can have horizontal or vertical diplopia as shown in these images. Lots of different things can cause this kind of problem, such as AMD, to name one of the more common ones, or one of the very uncommon ones, a brain tumour. But we just need to be aware of all these possible different causes when you're looking at diplopia. And then, of course, we've got lots of different causes of visual fields. So let's have a little test for ourselves, and we'll start at the top left and work our way around anti-clockwise. So have a little look at the first picture on the top left there and decide what you think it might be. And then the second picture. Number 3. Number 4. And then the next one. And the next. And finally, a little bit less familiar to optometrists, but no doubt you can see this one. So we all know that there's lots of different things that can cause visual field defects, and this is by no means an extensive list. Loss of contrast sensitivity is something that's often overlooked. People can see the detail, but the picture seems to be washed out. Have a little think. Do you have a contrast sensitivity chart in your practice? And now, have you actually seen anyone use it? Even the people who've got a contrast sensitivity chart will probably struggle to recall anybody actually using it in their practice, because it is something that gets overlooked, but it can tell us a lot about the visual status of your patient. So we know that all these types of visual impairment can be linked to dizziness and falls. But what evidence do we have? We're all told to use evidence-based optometry. So here's some evidence to help you along there. So a systematic review of the literature revealed that dizziness is linked to vision, so long as lightheadedness isn't included in that definition of dizziness. We also know that dizziness improves after people have had cataracts removed. So after you've made their vision better, their dizziness decreases. Another finding from Shupuk's study in 2016 was that if you make oblique cylindrical changes dizziness does increase, and this is something that optometrists have known for quite some time, but up until this paper there wasn't any evidence to support the anecdotal evidence. We also know that many people can't tolerate the tiniest of little changes to their spectacle prescription, and cylindrical changes are one of the most common causes of people to come back for a recheck because they're not happy with their spectacles. We've also got a study that I did between 2016 and 2018, and that's concentrated on spectacle remakes. So we came up with this study to ask, could we reduce dizziness by manipulation of the spectacle prescription? And also, can we induce dizziness by messing with the spectacles? And Specsavers opticians in 3 different locations were kind enough to allow me to have access to their patients to do this research. We examined over 1,000 patient records, and from that 488 letters were sent out to people to ask their opinion of their spectacles. So all these people had had spectacles that they weren't happy with, and they were then had a remake, and then we asked them questions about their new spectacles, and we had quite a good response rate in that 120 people returned their questionnaires to us. So we had the results from the Spectacle Adaptation Problems questionnaire, and we took other data from the record cards such as gender and age of the patient, etc. We excluded anyone who was under 18, and we excluded anyone who brought their spectacles back under the no quibble, no fuss guarantee, which lets patients bring their spectacles back for a change, even if it's just the frame they've changed their mind about within a certain time period. We also excluded people who only had single vision near vision glasses because dizziness is unlikely to happen when they're moving around, etc., because they generally don't wear them when they're moving around. And we also excluded those who didn't take the spectacles before we had a chance to amend them, with some people just come in with their guns blazing and demand a refund straight away, as we all know. We then classified the refractive correction changes into overplussing, overminusing, cylindrical changes, prism changes, etc. And we also defined what a major change would be. We decided a patient was indicating that they were dizzy if they ticked any of the boxes that said they had a feeling of dizziness, a swimmy sensation, a motion sickness feeling, unsteady when standing, or spectacles just not right and difficult to say why, because that is something that people do struggle with. They struggle to actually define dizziness. And one of the interesting things that we found is that 3% of people reported that they were dizziness. So that was on their record card that they came in and said that they were dizzy. However, when we asked the patients directly, 38% of them said that they were dizzy on the questionnaire. And this indicated that maybe dizziness was something that optometrists don't directly ask about, and they hope the patient will tell them. So what I would recommend is that you need to ask about the comfort of the spectacles. Ask specifically if the patient's dizzy, if they feel swimmy or imbalanced, because patients do find it very hard to describe dizziness. Now, in general practice, studies have shown that between 1.3 and 3.3% of sight tests end up with a remake. And I'm happy to report that actually these 3 Specsavers stores were at the very lowest end of this range, so well done, Specsavers. In other good news, 63% of the patients had their problem fully resolved by the prescription change. And of these, 75% were put back to their original prescription or within OT5 of it. 33% reported that their problem had been partially resolved, and 9% said they weren't resolved at all. So possibly some of these people had underlying dizziness that, of course, we can't do anything about with a spectacle prescription. So when we looked at the reasons for having a recheck, we had quite a lot of vague symptoms written on the record card. Now, we didn't count these as dizzy, but they could have been. So I would suggest if you get this kind of problem, I would just go a little bit further and ask the patient to clarify exactly what they mean by too strong. Does it feel that they're a little bit dizzy? Do they feel that their world is spinning? All that kind of questioning can lead you to much more precise answers. And when we looked at the change in spectacle prescription, this is what we found. So you'll see here that changes in cylindrical power and axis were the most prevalent. Varifocal and bifocal non-tolerance might have been down to the design of the lens itself. So we removed those as they could confound the evidence. And here's the results after we took out the non-tolerances. We've still got cylindrical changes as the main problem for dissatisfaction, and the second is overplussing. So remember, no near vision spectacles for reading out overplus. They weren't included in this particular part of the analysis. So next we decided to see if there were any differences between those who reported dizziness and those who didn't report dizziness. Well, the cylindrical changes were the biggest culprit of causing spectacle dissatisfaction, whether patients were dizzy or not. But the dizzy patients appeared to be more susceptible to anisometropia. So next, we had a look at the type of astigmatism. So for the purposes of this research, we defined with the rule astigmatism to have the negative SIL at between 180 and 30 or 150 and 180. And then against the rule astigmatism to have the negative SIL between 60 and 120. Oblique astigmatism was astigmatism that fell in between these ranges. And when we look at these data, we notice that the dizzy respondents were dissatisfied more often by oblique astigmatism changes, and the non-dizzy respondents were dissatisfied more by against the rule astigmatism changes. Now this study served as a pilot study really because we didn't get enough numbers to give ourselves complete confidence in the figures. So this study has in fact been extended, and the data is being gathered at the moment. So now you've got all the background knowledge that you need. So why should an optometrist actually be interested in dizziness? Isn't that something to do with the ears rather than the eyes? Well, as we've just seen, it's got quite a lot to do with the eyes. You should also always have concern for your patient, and if you can fix problems such as unsteadiness, blurred vision, problems with anxiety because they feel unsteady, then patients are going to love you and they're going to come back to you every time. There's also a concern for your business because, of course, remakes have financial cost and they also cost your reputation. So the question to ask is, can we fix it? And I think the answer is yes, we can. Most of the patients in this study had their problem fully or partially resolved. And most of these were changed to within plus or minus 0.25 or a 5-degree difference of their original prescription, which we defined as a minor change. So let's just quickly go back to the minor and major changes, and I'll let you know how we decided which was which. So what is a major change? And this is a paper that's used very often in dizziness research and in spectacle lens research. It's by Cumming et al. For 2007. And they defined a major change as a spherical change of over 0.75, a SIL change of over 0.75, a 10-degree axis change on a small SIL and a 5-degree on a larger SIL, any change to the prism, and any induced anisometropia of 0.75 or over. Can an optometrist help to reduce dizziness? And hopefully in the same time we might reduce falls as well. Well, you can specifically ask about dizziness and falls. So when spectacles are worn, do they have problems with steps and stairs? Do they feel comfortable vision-wise? Does the world move when they move, or does everything look pretty crisp and clear? We can reduce blur and distortion. We're good at that. We've done that lots of times. We can make sure the spectacle prescription is as accurate as possible and use the skill of the dispensing optician to reduce any distortions from different lens designs, etc. Tinted lenses might help with contrast sensitivity, especially in early stages of cataract, etc. And make sure your patient is aware of any field loss. They might come to you and tell you that they're bumping into things on the right hand side, for example, but wonder why. They might feel that they're clumsy rather than the fact that they've actually got part of their visual field missing. And it's your job to tell them that this is the reason why this is happening. Of course, we all advise on the type of spectacles and when to wear them. And this is especially important in the testing room, as well as in the dispensing area. And if our patient needs any treatment at all, such as low vision assessment or cataract extraction, we can refer them to the appropriate secondary care practitioner. So to reduce blur and distortion, we do an accurate refraction, which is great because that's what we're good at. But just be careful and remember that older people struggle to adapt to change. A randomised controlled trial by Cummins showed that falls are more common when someone's given their full correction rather than a tiny change at once. So people don't like a great deal of change, especially when they're older. So remember, if it ain't broke, don't fix it. If change must be made, be conservative with a small c. When referring for cataract surgery, surgeons love to make people into emmetropes, so they just need a pair for reading and they can walk around without spectacles on most of the time, which is great if you're having both eyes done. But if you're -5 and you just have one eye done, you'll end up -5 in one eye and plano in the other. Now, you're not going to adapt to that in any period of time. The best that you can hope for is that one eye gets suppressed. So make sure that the patient is aware that they might have an adaptation period. They may feel a little bit strange in the interim period between having one eye done and the other. And we'll go back to Shupuk's paper again, because she found a significant link between post-operative falls and a change in spectacle type. So if your patient has been used to a bifocal for years and years, keep them with a bifocal or pop them into single vision if they just want readers. If you go changing the spectacle type, for example, swapping them to a varifocal from a bifocal or the other way around, you're risking causing problems with falls. So again, with change of spectacle type, if it ain't broke, don't fix it. And that includes the type of lens and the type of multifocal. If a patient has good vision and they're active, it's worth considering using a single vision lens for outdoor activities, such as if they go hill walking, etc. However, with an inactive patient, you're more likely to cause them to fall if they end up swapping glasses. With low vision patients, for spectacles that they're using outdoors, they're much better off with a standard ad rather than the high ad. The high ad should be left for indoor use only. So with regard to spectacles, a study in 1984 showed that 71% of older people own a distance vision pair of specs, but only 47% use them. 57% didn't believe they needed them. And 35% feared falling or being dizzy. And 7% of the people complained that the reason they didn't wear their spectacles was because they were too heavy or irritated them. So don't forget that when a person gets older, their skin loses its elasticity and they have a thinning of fatty tissue around their face. So you would want a lightweight frame to combat these two problems. So your frame fit, very important. And if they've got a moderate to high prescription, ask them to wear them all the time rather than swapping all the time. And this will help them to keep their adaptation at a good level. Advise them on the care of their spectacles. This same study found that only 56% of spectacles were in actually a reasonable condition. Many were dirty, scratched or damaged. If you're unable to help your patient by modifying their spectacles, then if their vision is poor, you might want to consider referring them for home safety modifications. And these include installing grab bars and stair rails, but also really kind of almost obvious things like removing loose floor mats and getting rid of the clutter. A study by Campbell in 2005 showed that introducing these modifications in people's homes could reduce falls by 41%. So in conclusion, if it ain't broke, don't fix it. If a patient's happy with their prescription, leave them alone. The only time you would perhaps change it is if they didn't quite meet the driving standard, and in that case you'll change it as little as you can get away with. So leave the spectacle type, the design and the prescription well alone if the patient's happy and the vision's adequate. The second thing is don't mess with the sills too much. People are notoriously dislike having their sills messed with, so if you can leave them alone, please do so. And especially with older patients, make sure any changes that you make are very small. And here are some references if you want to have a further delve into this subject. And I'd like to say a public thank you to the College of Optometrists for sponsoring my PhD, and to the University of Bradford for allowing me the opportunity to research, and to Professor David Elliott, Dr. Alison Alderson and Dr. Chris Davey for allowing me access to their amazing expertise. Thank you.